Hello and welcome to my presentation on mental health comorbidities in adolescents and young adults with autism spectrum disorder. My name is Cheryl Checkers and I'm a licensed mental health counselor in private practice where I specialize in treating adolescents and young adults with both ASD and a mental health disorder. In the past, I worked as a clinical support specialist for FAU CARD and as a clinical director for the National Alliance on Mental Illness, where I am currently a board member. So the learning objectives today, to recognize common comorbid mental health disorders in adolescents and young adults with ASD, to differentiate common mental health symptoms from symptoms of ASD in adolescents and young adults, to understand diagnostic considerations for treatment of mental health symptoms in adolescents and young adults with ASD in the community mental health and educational settings, and to utilize case conceptualization to inform treatment of mental health symptoms in the context of ASD challenges in adolescents and young adults with ASD in the community mental health and the educational settings. So let's get started. Why we are here today. I always like to start with some statistics because it really paints the picture of where we are today with regard to treating individuals, and today we'll be talking about adolescents and young adults who have both ASD and comorbid mental health. Most recent research in March of 2020 by the CDC, children diagnosed with ASD is now 1 in 54. 70% of individuals with ASD have co-occurring mental health issues. So that's a large majority of individuals with ASD that have co-occurring. 40% have 2 or more co-occurring mental health disorders. And this is designated by the DSM-5, the research they've done. Individuals with ASD are twice as likely to exhibit symptoms of a mental health disorder than their neurotypical peers, even in adolescence and young adulthood. And ASD can mask mental health disorders, which is, what I'm going to be going over in more detail today. Over 50% of mental health professionals have little or no training in working with ASD, and fewer than 16% of therapists haven't had supervision with expertise in working with clients who have ASD. So that really paints the picture of and makes a case for this cross-training so that mental health professionals have more training in ASD, and then the reverse as well. ASD specialists also have at least a broader understanding of how mental health issues might present. So one of the most common questions I'm asked as a mental health clinician who specializes in ASD is, how do I know if it's ASD or a mental health disorder? And this is, a very difficult question, as you all know, a very difficult question to answer, and something I'm going to be trying to answer today during this training. But, it is very difficult. There's so much crossover in the symptoms, and even somebody that has a great deal of specialty or a great deal of experience in both mental health and understanding ASD, it's expected that there's some difficulty in differentiating, is this a mental health symptom or is this a symptom of ASD? So just to kind of give you an idea of the difficulty and what we need to go through, the process we need to go through to distinguish mental health from ASD. So when we're looking at ASD or social anxiety, there's deficits in eye contact or inability to read emotions of others. So is it that, or is it, social skills deficits or social phobia, inflexibility and difficulty managing change, or is it an anxiety disorder? So kind of looking at, is it that core deficit of ASD? Is it, does it meet criteria for social anxiety? Again, that's something we're going to be going into more. ASD or depression, lack of interest, or decrease in functioning. So that's a big issue with differentiating between the two. lack of social acceptance, or social withdrawal. So, kind of posing these questions, and then as we go through the presentation, hoping to answer some of these questions in detail. So ASD or bipolar, mood swings or inability to regulate emotions, or is it meltdowns or rage? Irregular sleep patterns or inability to sleep, like with oppositional defiant disorder, or rigidity versus control. With eating disorders and ASD, differentiating food sensitivities from body image issues. ASD or obsessive compulsive disorder, area of interest or perseveration, or does it meet the requirement of anxiety driven repetitive ritualistic behavior? And ASD and ADD, inflexibility and difficulty managing change, or is it a true anxiety disorder? So just some of the challenges faced when we're looking at both. So distinguishing, when do we consider assessing for a DSM-5 diagnosis? And the rule of thumb typically is the emotional behavioral symptoms, are they above what we were seeing before, above baseline? So is there, knowing that, and again, doing more exploring of this throughout the presentation, but just starting to talk about this, knowing that a typical mental health symptoms can appear much differently in individuals with ASD. So, it could, cause some of their typical behavioral issues to increase. And so rule of thumb, like, are we seeing something different in emotional and behavioral symptoms that are above what we would see as a baseline impairment related to symptoms of ASD in an adolescent or young adult? If there is an impairment, then that's when we consider screening for a mental health disorder. We certainly can see typical symptoms as well, but if we're also seeing like an increase and we're wondering, we can't explain where that's coming from, then that is a good time to do that assessment or that screening for the mental health disorder. So again, knowing that adolescents and young adults with ASD don't always exhibit those typical mental health symptoms, but being aware that that could mean more. That could mean that it's a mental health disorder. So walking the line, that's a big thing we do, right? As clinicians and ASD specialists as well, educators. We consider expected increase in symptoms relative to present challenges also, like puberty and transitioning, which I'm going to be talking about, particularly with adolescents and young adults, transition to high school, transition to post-high school. Could that be, parsing out, like, is it the ASD symptoms? Is it a change in expectations or transition piece that maybe the individual is having a difficulty with, doesn't have the life skills to be able to navigate? So we're going to be looking at a lot of things when we talk about walking the line. One of the first things we do is with ASD is we also must consider, as mentioned with the life skills, are the symptoms above and beyond what would be expected based on the present challenges? So first looking at behavior and emotional behavioral symptoms, is that above what baseline is? Then the next, considering what are the symptoms, what are the usual challenge or the typical challenges we would expect to see at this point with puberty, post-high school transition type thing. And so this is where it gets a little more complex. There's three different areas to consider, but the most important thing is that we look at which symptoms are causing the most impairment in daily functioning. So we can, whether or not there's a full diagnosis or enough criteria to meet a diagnosis, we're starting to provide support, provide counseling, provide whatever it is we need to do to decrease that impairment. And some of the other things we want to think about is in which environments do we offer support for ASD challenges, for life skills challenges, and for the mental health challenges. Is it in school? Is it in the home environment? Is it in the counseling environment? Is it all three environments that will be, and I'll be getting into this when I talk about treatment conceptualization, on how we kind of look at the treatment goals and then determine which environments they will be, approached or support will be provided in. The big question again is, do we have to choose between treating the symptoms of ASD or treating mental health symptoms? And the real answer to that, going back to the question, how do we know, if it's ASD or if it's mental health? We want to offer support. So no, we don't have to choose between the symptoms. In fact, to really have the most success is to treat both, to identify the core symptoms of ASD that are causing some impairment that might be leading to the mental health challenges, and also to look again at those environment pieces, and do we need to build some life skills in. So it's really taking an approach of, we need to look at this as a big picture, and not so much whether we have to just treat the mental health or we just treat the ASD. So where do we start? Again, a good compass is to start with the symptoms that are causing the most significant impairment in daily functioning. So going back to kind of a graph to underline or validate some of the things that I was suggesting, that we might see a typical presentation of mental health symptoms in the adolescent or young adult with ASD. We might see an atypical presentation, or we might see both. We might see some of, we might see like acting depressed or isolating, or an increase in the emotional symptoms, and that look more like a typical depression. But we also might see an increase in meltdowns or other like what we would consider to be core symptoms of ASD. But regardless of what their presentation is, assessment for mental health disorders is warranted because it's above baseline. So and also if it is, we're seeing symptoms that are very severe, not only above baseline, but pretty severe. Considering a medication assessment at that time is also something that, that I, with my own clients, always, will refer for medication assessment if I feel that it's a severe presentation. And another thing, and I'm going to be getting into mental health screenings and assessments, but also to be aware that when you do provide assessments or screenings to an individual, and we're talking about adolescents and young adults with ASD, it is always, it is helpful to be able to clarify what their answers are to the questions. Sometimes they may misread the question in an assessment or a screening, or they may answer in a way that just because they're not sure of how to answer, they'll give an answer. And it's really important to clarify, if you feel sad all the time, and they say yes. What is that, and kind of going over, well, what is it like at home? What is it like at school? What is it like, out in the community kind of thing, so that you get a better picture of what they mean, and allow them to ask questions, and just, be very sensitive to knowing that, especially with us clinicians that are used to giving screenings and assessments, that some of the questions may be taken in a very concrete way, and it's helpful to make sure that, that they understand and that they're answering, they're answering the question in the correct way. So distinguishing ASD from mental health, the impact of ASD on expression of co-occurring mental health conditions. So this, I started to get into a little bit, and this is so important because these are the three areas that we really need to take into consideration when we're thinking about assigning a mental health diagnosis. So being aware that mental health disorders can exacerbate core ASD symptoms and the reverse. And, core symptoms of ASD can appear to be depression or can be depression and be appearing in an exacerbation of symptoms. And that it can cause a further impairment in quality of life. Also the life cycle changes, and I'm going to be getting into more detail about those. And those are the transitions, the transition to high school, the transition to young adulthood, post high school, puberty, other things like that cause challenges to even a neurotypical adolescent or young adult. And then our folks with ASD may be having an even more difficult time to navigate them because maybe they don't have the appropriate life skills in place to help them. So how do we parse all this out? And that, we do the best we can, and I'm going to kind of give you a template for doing that. But, just the awareness, I think is so important, particularly, so I'm a mental health counselor, and knowing that, my colleagues and the way that we approach things and being more mental health than ASD, I think it's really important that this education, and part of why I'm doing this training today, is to spread that awareness that we have to combine everything, and we have to have more education and understanding of what we need to look for, especially when we're treating mental health, I feel, in adolescents and young adults with ASD. If we just treat the mental health, we go in for the depression or the anxiety, and we don't look at what might be happening in those life cycle changes, those transitions, or we don't look at the core ASD symptoms, chances are we're not going to be that successful. So understanding all of these pieces and how they all work together and how the presentation may look, that is where we're going to have the most success when we go in there to treat symptoms of mental health. So the triad of impairments, core symptoms of ASD, the social deficits, communication deficits, and restricted and repetitive patterns of behavior. We want to consider all of those components, and at the same time, certainly to consider sensitivities, executive functioning issues, and making sense of emotions or emotion regulation. Understanding the emotions of others. So how these triad of impairments might look in adolescents and young adults is here. So as the social world becomes more difficult in high school and more is expected of individuals with ASD and in the environment, you see that some of the typical struggles, but they're just on a different level. So there's another area where it's very difficult to understand, is this just like is this a typical transition that a neurotypical individual might be having difficulty with? And if so, if the individual has ASD, how is that making it even more difficult for them? So making sure that this is understood as part of that triad that I was showing you, how it might present difficulty making conversations and problems with reading and understanding the emotions of others in the high school setting. What does that mean? The social world is changing. Are they able to do that? Do they understand the social rules? Do they have skills for making and maintaining friendships or relationship skills? Is that, could that possibly be part of what is leading them to have some mental health symptoms? That regulating emotions is a big one, especially, for adolescents and young adults that I see that have ASD. That tends to be something I'll see more often than not, is that problem with regulating emotions, and then it's less acceptable in the high school environment. Peers could be, less accepting of that, and may tease or make fun of, bully, that kind of thing. extreme interest in a specific topic. How does that look in the high school environment? Is it, is that, playing a part in this big picture? And, some of the other things that we tend to see from early childhood on, like the frequent monologues and the restricted interests, the preference for solitary activity, and oftentimes that might be because the individual doesn't know how to interact or is tried and maybe isn't accepted, and so they prefer solitary activity at that point. Dealing with change and hygiene becomes a big one. I'm sure that you've all seen this. Once high school, puberty sets in, that having a healthy hygiene schedule of what needs to be taken care of before they get to school. Oftentimes they don't do what they need to do, and then again the peers aren't very accepting of that at high school. What does that look like? The hypersensitivities, difficulty adapting to new and the increasing challenges like problem solving, navigating, and complicated social cues, deficits in adaptive skills, responsibility, accountability, appropriate responses, adapting to change. All of the, if we think about the high school environment or even post high school, what is required, and then we wonder and certainly want to assess and determine, is this something that they have the skills to do? Is that something we need to consider in therapy? So I have included some of the assessments for ASD, and I wanted to just talk a little bit about this because there are free screenings. There are others that can be purchased, and it's important because oftentimes we'll see, and I know both in the educational setting or in therapy setting, we'll see individuals who were diagnosed very early on. And we can look over their reports and their earlier assessments, but that doesn't always give us a picture of where the person is today, particularly when we're talking about adolescents and young adults. So what I like to do and what I like to, put out there for you to consider is maybe doing one of the assessments or screenings as a tool, not so much to diagnose at this point, but for treatment planning, to understand where the adolescent or young adult is and what level what are they functioning at? What's their current level of functioning? And just to take, for example, the GARS-3. So it takes 5 to 10 minutes to complete, and a parent, a clinician, and an educator can all, fill it out. And it provides a really good picture of, where is that individual, in the areas of restricted repetitive behavior, social interaction. It looks at social communication, emotional responses, cognitive styles, and maladaptive speech. So looking that over, you can then, very quickly see a picture of where that person is as far as their core ASD impairments at this point. And that can be used for treatment planning, which I'm going to be getting into more, but I just wanted, to have that on your radar and just to consider. And it's certainly important to look at early reports and getting a developmental history, but determining where that individual is right now today. It's very important to make sure that we're not going off an older assessment, but we're looking at something that's a little bit newer, and it can be done pretty easily, even with some of the free tools that I have listed here. So understanding the impact of life cycle changes in adolescents and young adults with ASD. So I just talked a little bit about the core ASD challenges, and that other piece, which is, one of the earlier slides, is also the impact of life cycle changes. So that's so important. Again, how is this presenting in possibly in a mental health symptom, or even increasing the core Asd symptoms. So the common challenges in adolescence, navigating the social minefield of high school is huge. So, if we consider they may not have the skills to navigate now that expectations and, the requirements are higher to be able to navigate, we want to make sure that we understand if that is the case. The self-care that I mentioned, the hygiene, we want to make sure that we're looking at, what's going on there. This is a common challenge, but, is this person, is this adolescent or young adult with ASD, why is that a challenge for them? And looking more into that as one of the life cycle changes. Puberty brings with it so many things, so many challenges for the adolescents and young adults that I work with. It usually, what I see is an increase all around in symptoms, and oftentimes it is that the puberty, the hormones, and it's certainly when there's emotion involved, when there's some anger, aggression, or sadness, or whatever it is that the person may have been. It may have been a challenge for them to begin with. Now they're in puberty, so seeing an increase, understanding could that be part of the reason. Sexuality issues are really big. So the social world becomes more complex. Social isolation and withdrawal. More than 40% of the teens with ASD never saw friends outside of school. Half were never invited to take part in activities. For 45%, friends never called. So this is another big piece that we're going to see in adolescents and young adults. The social world becomes more complex, more social isolation, more withdrawal. But is it because they're depressed, or is it because they don't have the skills, or is it a challenge that they've always had, and now because the social world is more complex, they're not able to use those skills that they had? So that's another important area. The increased executive functioning is something I see quite often as well. The struggles with that. So there's more personal responsibility. There's not, and as you know, in high school and certainly post high school, there's a lot more required in the way of executive functioning. And sometimes individuals with ASD, adolescents and young adults, just don't have the tools to be able to do that increased executive functioning. They can do it, but it needs to be part of our treatment planning if that is a problem or a struggle that they're having. What can we do to increase their ability to be organized, or to take more personal responsibility as dictated by whether they're in high school or post high school. The increase in peer pressure is huge. So the rejection, the teasing and bullying, maybe that was going on already. Maybe, maybe now it's increased, or maybe that it's something that the individual never experienced before. And now because they are in the high school setting and the social world's more complex, and what their behavior may be less tolerated or accepted, maybe that's when some of that's happening. So that's something we need to have on our radar as well. The desire for independence is in conflict with ability, which is huge as well, because oftentimes adolescents and young adults really want to be independent. They really want to do what their neurotypical peers are doing. They're just, they don't have the ability to do it. So that desire is there, but maybe the ability to do it isn't. So that's something else. And again, thinking about these things, even that desire for independence and not being able to do it, that can cause depression. That can cause, anxiety. It can cause all of these things can cause, mental health symptoms, or what might look like a depression, but it's the cause is based in that common challenge that they're going through without the tools that they need. So when it comes to those, do they have the skills to navigate those life skill changes, or the, life skill transitions, whatever you want to call them? It's really more of a looking at, do they have the life skills and the transition skills in place that they need to be able to master the transitions that they're, facing? And oftentimes they don't. And oftentimes, and I work with a lot of individuals that have very high IQs. They're oftentimes people around them are saying, I don't understand why he or she couldn't do that, because they're so smart. And they can do it. It's just that sometimes that, they haven't been taught it yet, or they haven't had enough practice, or they might have been taught, but they aren't unable to generalize to different environments. So, but it is so important to make sure that this is part of treatment planning, part of that big picture, because if not mastered, this can have such a profound effect, not only on what they're going to achieve after high school, but to be successful in high school, to, to be able to have relationships with peers, to be able to take part in social activities, and to prevent, or, at least build in, if they are depressed because of this, that we build in those skills as part of that plan to work on, maybe if they are feeling depressed. Certainly, if we can be proactive with this is even better. But, oftentimes it's after the fact, and that's okay. It just has to be on our radar that this is one of the components that we need to assess for, so that we can make sure that we're going to set this individual up for success. So, assessing or screening for their basic living. And I put some kind of basic ways that you can assess if you're not, just going to ask questions. Sometimes people have their own set of questions they want to ask about transition. If you want to look, at some of the assessments, the screenings, I have some of them listed here. Again, informing treatment, we want to get, the base, we don't want to look, at the very early assessments, or if we do look at them, we don't want that to inform the treatment. What we want to do is, where are they now? So maybe they were functioning very well in the area of life skills very early on, maybe in, elementary school or even middle school, but where are they now in high school or post-high school? Are their abilities such that they're able to handle those typical transition pieces that we would see in adolescence and or young adulthood? So consider either one of these assessments. There's a lot of different assessments and screenings out there that can be used. And this is really important. I know it, in both the educational setting, in a clinical therapy setting as well. Again, the thinking of those three components, the core ASD symptoms, the mental health symptoms, but we also want to consider the life skills, or the, what's going on at this particular time. And if we don't, address that, we're not really addressing the full picture. So some of the skills that are really helpful to be able to be successful with these transitions I've listed here. And I also have a quote from the World Health Organization that I think really is impactful as far as describing how important this part is. They define life skills as abilities that help us to adapt and behave positively so that we can deal effectively with the challenges of everyday life. So some of the things that some of the areas that are commonly seen as deficits in adolescence, young adulthood, is self-management skills and self-advocacy, navigating the life cycle changes, the independence, success in educational settings, ability to take advantage of social and recreational activities, friendship and relationship skills. And some of these, is certainly something to consider of, is this something we incorporate into the IEP in addition to a therapist incorporating it into their treatment plan? Is it something we're going to incorporate into the home environment as well? Are we going to consider life skills education for the parent and caregiver in addition to what is going to happen in the school setting and the therapy setting? That is usually where the most success happens because of the difficulty with generalization in different environments. So having everybody on the same page is what I like to call it. The parent and caregiver, the educators, and the therapist, so that everybody's working on supporting those life skills. And just one final, for as far as counseling sessions, teaching the life skills and then assigning homework for generalization of skills in the home and the community environment as well as the educational environment is really important. Again, with very difficult for our teens and young adults with ASD to learn something in one setting and then be able to assume that they can have the skills and know what to do in different settings when oftentimes that's not the case. Now I'm going to be getting, so I've covered a little bit of the core ASD symptoms and what they may look like in teens and young adults with ASD. I've talked about the life cycle challenges or the transitions piece with the life skills. And now I'm going to be talking about common mental health disorders in ASD and what do we see there. So anxiety disorders affect up to 42% of individuals with ASD. And in the general population, only 3% of children and 50% of adults. So as most of us know, or all of us know, individuals with ASD have anxiety seems to be a component that's just built in. But, considering these other things that I discussed, the life cycle challenges and some of the deficits that can increase the anxiety, it's not, it's certainly understanding that the percentage would be that high of the anxiety if the baseline is already there pretty high and then you add these other layers on. It's not unusual to see then anxiety disorders. ADHD, certainly real high, again, 30 to 60% of individuals with ASD versus 67% in the general population. Depression affects an estimated 7% of children and 26% of adults with ASD. By contrast, 2% in children and 7% in the general population. OCD is, certainly another one that our teens and adults with ASD have a pretty high prevalence of. And over half of children and adults with ASD, and possibly as many as 4 and 5, have one or more chronic sleep problems. So the sleep problems are something I'm going to be getting into a little more detail on, because that is so important in this picture as well, to know that there's already a baseline difficulty for most individuals with ASD and how that might look if there's a mental health disorder thrown in. And also, thinking about the reverse, if the sleep problem is significant or, it's disruptive enough, then that can certainly lead to or be the cause of some of the mental health symptoms we see. And so there are some very common mental health warning signs, and this is, these are the signs that National Alliance on Mental Illness provide to settings that want to screen for individuals that might have a mental health disorder. And certainly all of these can be seen in our adolescents and our young adults with ASD. So the typical like feeling sad or withdrawn for more than 2 weeks, the out of control risk-taking behaviors that could cause harm to self or others, like fears, overwhelming fears, panic attacks, like the racing heart, or you might hear an individual say, I feel like I can't breathe. The seeing or hearing or believing things that aren't real, drastic changes in mood, behavior, personality, or sleeping habits. And that's what I was saying earlier on, the baseline. It's usually when you become concerned and really want to start assessing and screening is when it's something above that baseline. So the changes in mood, behavior, personality, or sleeping habits, extreme difficulty concentrating. You may hear, that I keep reading the book over and over, and I have to, I can't, absorb it. I need to continue to read it. Intense worries or fears that weren't there before, or an increase in worries or fears that were there before, vomiting or using laxatives to lose weight, using drugs or alcohol excessively, or using it if not, used before, and certainly trying to harm oneself, or suicide attempts, or making a plan, or even talking about suicide. So all of these can be seen in our individual or adolescents and young adults with ASD. They can present with very typical types of mental health symptoms. But it's also important to be aware that mental health may look very different in our teens and our young adults with ASD. So any type of new symptom or an increase in their previous level of difficulty can also be a warning sign. So aggression or aggressive behavior, self-injury, regression of previously learned skills. So I hear a lot of parents say to me, well, he used to be able to do that, or she used to be able to do that, but or she was able to handle her emotions a little better in the past, and now she can't do it at all. So that's that regression of previously learned skills. So they may have been able to, but now the bar is raised a bit, and it's too much for them to be able to control. The self-stimulation, the self-calming behaviors, and increases in those behaviors are a sign. You'll see the perseveration on area of interest, but it would be more of like an increased perseveration where you're going to see a noted difference. Meltdowns are an increase in number of meltdowns. The number of meltdowns increasing is a very typical area of seen when there's mental health involved. Isolating or increase in isolation. So maybe it was, I don't really, want to do a lot, outside of my room, but now I'm not going to come out of my room. So that increase, or if they weren't isolating before, now they are, certainly a sign as well. School refusal is very common. And again, the sleep problems or increase in sleep problems. Don't want to get up in the morning, which is a very typical response even with our neurotypical teens and young adults, but this goes beyond that. It'll be, it's very difficult to get to sleep at night, and then wanting to sleep throughout the day, very tired in the day because they do have to get up to go to school or to go to work if it's post-high school or college. But again, above baseline, this is more than what I was seeing before. Something's wrong. So to speak more specifically about some of the more common mental health challenges and how they might look in ASD. So ASD and anxiety. So again, I can't, I want to be sure that the understanding is they can certainly show very typical signs of anxiety, but at the same time, they may not show it. They may show it very differently in these increase in Asd type core symptoms, or there might be a mixture of both. So being aware of both is so important. Oftentimes, you know, mental health counselors might say, but they're not, you know, they're not showing any of the symptoms we see in the DSM-5 under anxiety or under depression, but maybe the presentation is just different. So that's where this education is so important, what to have on our radar. This is how it could look. So with social anxiety or with Asd and anxiety, social anxiety disorder and generalized anxiety and OCD are the most common that we see. This, you know, anxiety can be a consequence of the social demands. It can be a consequence of the change to the daily routine, the transition that I was suggesting, or even not knowing what to expect can cause anxiety because they're in a new, you know, a new pattern and just, you know, unaware of what's going to be expected of me next. Repetitive behaviors may be a way to cope with their anxiety level. That's something I see very often. So, you know, knowing that that might be a way for them to regulate their anxiety. Maybe don't have a lot of tools to deal with the anxiety yet. So, you know, what can we do? Well, you know, that their bodies, you know, oftentimes this is the only thing that they can do as a way to try to regulate that increase in anxiety and that a negative feeling for them is that their repetitive behaviors increase. Anxiety may further complicate insistence on routines because, you know, for anyone, when you're anxious, or most people at least, you know, knowing what to expect is somewhat comforting because then you don't have to think too much. You don't have to worry about not knowing what to expect. So that it might be seen in that, you know, insistence on routine. And certainly, again, distinguishing the anxiety of component is so very difficult in Asd. I have listed some assessments and screenings for anxiety disorders. They're not specific for individuals with Asd, but they're a good start. There are a lot of really good questions in these assessments and screenings to not only understand the full complexity of the symptoms that the individual might be experiencing, but or at least to begin to understand so that you can do more questioning and more exploration once you know what areas are affected. But the assessments and screenings are really a good way to understand or begin to understand and to do the treatment planning. Again, understanding that sensitivity piece that, you know, that if it is the teen or young adult that's filling out a self-assessment, make sure to go over it with them after they fill it out, make sure they answer correctly, make sure that they understood the questions correctly is really important. So these aren't an exhaustive list, but I've listed a few of the screenings, and a lot of them are free and can be grabbed off the internet and they're free to use. So for clinicians, even in the educational setting, the counselors, school counselors, this is really helpful way as long as it's known that you have to oftentimes be very sensitive to whether or not the question's understood. Also, having information from educators, from parents, caretakers, to help a clinician better understand what the full picture is with anxiety is really helpful. So talking a little bit about depression and Asd, oftentimes mood disorders and depression can have a very different cause than what we would see in a neurotypical individual that's exhibiting signs of depression. And it's really important to understand what those different root causes might be, because it can place an individual at higher risk for self-harm or suicide if the depression goes unnoticed and therefore untreated. So, you know, the sense of being very different from the peer group, particularly in the high school setting or even post high school, is so important to you know, just assess for their feelings surrounding that. Difficulties in forming and maintaining relationships can add to the depression. Self-isolation and loneliness, oftentimes stemming from that inability to maintain relationships. And then again, having that it kind of all related, you know, if they can't maintain relationships and they're isolating, are they also being, you know, teased and bullied? And again, sleep problems come up because that's such an important piece of all of this. And behavioral challenges, lack of structure or routine. And I see that particularly in post-high school, so that, you know, school, there's that routine in place. I get up, I go to school, I, you know, have my classes, I do my homework, you know, and having that routine, which is so good for anybody, but particularly for our teens and our adults with ASD, and all of a sudden that falls away. So there isn't much structure there, and oftentimes that is the cause of depression. So making sure that that's all, you know, screened or assessed. So assessing mood disorders, particularly depression. Again, you know, as I did for the anxiety, and for the life skills, I'm including some assessments and some screenings. Some of these are free. Again, they're very easy to find on the internet, and they're, you know, available to use. And it can be really, really helpful, just determining what the symptoms are. And, you know, this is before, you know, really knowing, you know, which pieces play in, you know, is it the transition, the life skills, is it the ASD components, but at least it's given you an overview of these are the areas of struggle right now. And this is then kind of circling back to understand what the fuller picture looks like. And again, with sensitivity to the way that an individual with ASD might answer on these. Being able to have as many people in the person's life that can give you this, what they're seeing is so important too. Again, educator, parent, caretaker, and clinician. If you know, we're thinking about all three of them, regardless of which venue they're receiving support in, getting that, if it's in the educational setting, getting, you know, the feedback from the counselor, the clinician, and also the parent caretaker, you know, is so helpful. So if any of you have seen any of my presentations in the past, you're not going to be surprised that when I talk about depression and ASD, I'm going to talk about suicide. It's a hard discussion to have, but it's something that I feel is really important because the numbers are really high. So according to research, 67% of adults with ASD reported suicidal thoughts, and 35% reported having specific plans or having attempted suicide in the past. According to the CDC, suicide was the second leading cause of death for young people, ages 10 to 24 in 2014. So there's some really big numbers here. In females with ASD, 3 times the risk for suicide compared to their neurotypical peers. Children who reported bullying were 3 times more likely to consider or attempt suicide than children who did not report bullying, which is huge for our ASD population. 60% of children with ASD reported being bullied. So that is a very real concern when we're thinking about depression and, you know, what could happen if, you know, we're not catching the depression in time, or even if we are, we still need to be aware of the risk for suicide. And I know oftentimes the people that I've, you know, talked to over the years, that they somehow tend to think, well, because of their ASD, they probably aren't, you know, going to think about suicide, or their thoughts they're not probably able to, attempt or even, come up with a plan, but they are. I mean, it is something that we need to be aware of. And because they have ASD, actually increases the risk. So research shows that adolescents and young adults who are depressed and more cognitively aware are at the highest risk of suicidal thoughts and behavior. So that's something, again, another reason why we have to make sure that we're assessing for suicide. And also the good news is that research has shown that recognizing and treating depression as early as possible, and again, here comes all the pieces, working to improve social relationships and social skills may help reduce suicidal thoughts and behavior. So again, another, another underlying or validation of why it's so important to look at all those components. So signs of suicide, the typical signs, which certainly again, in our teens and young adults with ASD, you can see these typical signs. So I'm going to go over them just because of the importance and just so that we are all aware that it could look like talking or writing or drawing about death, talking about having no reason to live or being a burden to others. They might be talking about not being here tomorrow or next week, feeling hopeless, desperate, looking for ways, giving away possessions, loss of interest in things they care about, behaving recklessly, or anger, irritability, or violence. So at the same time, they may not show those signs. So it's very important, again, if they appear very depressed or even show a couple of those signs, or just, that aren't doing, again, that baseline, looking at that baseline, do I need to assess for suicide? And asking the questions does not cause somebody to actually follow through with suicide. So there's an Ask Suicide Screening by the National Institute of Mental Health, and they actually have a full toolkit that's accessible on their website. It's really helpful. So the questions that they have in their assessment, and they're very direct questions, which I think is so important, particularly when we're dealing with adolescents and young adults with ASD, because they don't always get like more nuanced questions. So if we're not comfortable asking the question, and we might say, have you ever wished you weren't here? They might say, well, yeah, I don't want to be at school. I don't, of course, I wished I wasn't here. So very, very direct questions are the best. In the past few weeks, have you ever wished you were dead? In the past few weeks, have you ever felt that you were a family, or your family would be better off if you were dead? In the past week, have you had thoughts about killing yourself? Have you ever tried? If yes, how? You want to find that information out. If yes to any of the above, are you having thoughts of killing yourself right now? Which of course then would require going to a hospital or calling 911 in some cases. But certainly if the suicidal ideation is something so strong that they're actually considering it currently, then there's a different, we need to act quick, and we certainly better safe than sorry in any of those instances. So calling a counselor if you have one, calling 911 if that, if it's required. The biggest takeaway here, I think it's really important to make sure that, especially clinicians that maybe don't have as much experience working with ASD, that they do ask those direct questions. Have you ever wished you were not here is not good. Question for our individuals with ASD, it's have you ever wished you were dead? And again, I know this is very sensitive. It's really hard to even say those words, but it's necessary to know that we have to assess if warranted. So ASD and PTSD, this is a area where in my practice and in the years that I worked in agency work, oftentimes that teasing, bullying, that peer rejection can be seen as very traumatic for our teens and our young adults with ASD. So, and so they can report a broad range of life events as traumatic that maybe we don't necessarily see in neurotypical individuals. So consider treating for trauma regardless of whether the individual meets DSM-5 criteria for PTSD. It's so important because, you know, by the DSM-5 being our Bible for clinicians, you know, okay, they don't meet this criteria. They don't meet, maybe they only meet, you know, a couple of the criterions. But it's still really affecting them. So, you know, this is, you know, an area that we want to treat. And so just being aware that that is, you know, with individuals with ASD, they may not always meet that threshold for DSM-5 diagnosis, but it's still important to treat those symptoms. Certainly knowing that our teens and our young adults may be at and are at increased risk of experiencing victimization and probably have very limited coping skills in most cases to respond to these experiences. It's very important to teach those coping skills as well, because if you're treating the trauma and they're still going into maybe an educational setting and they're still being traumatized every day, treating the trauma, but it's still happening. So consider teaching the coping skills in addition to treating the trauma. Using trauma assessments, it's helpful to use self-reports, but also reports from different sources, such as parents, caregivers, teachers, and also to be aware that if you start a trauma protocol, if an individual with ASD has OCD type behaviors or has the OCD diagnosis, it can cause them to perseverate on what you're talking about. So that, and then it becomes, everything worsens. So the ASD symptoms worsen, the mental health symptoms worsen, and you really want to consider treating the OCD, symptoms before attempting trauma treatment, or at least be very sensitive to what it could cause. Oftentimes I see like an excessive rumination on you know, that area. If you're talking about bullying, maybe, then they start to ruminate on it and they can't get their mind off that area. So they're leaving the therapy session, or they're leaving the educational setting, whatever the case may be, and their mind is still going over it and over it and over it, and then causing the worsening. So just be aware of that. That's an important piece to be aware of. Here's a couple PTSD screenings. There's some, again, that are free. This can be a really good way to just understand what the symptoms are, because oftentimes our teens and young adults with ASD might not be as aware, self-aware. So if they're asked, you know, how are you feeling, or, you know, how did that make you feel, they might not know to be able to describe the different things that we might see, you know, typically in someone that's experienced trauma. So those checklists can be really important, and even to just start a conversation. I see that you check this, you know, what is that? How did that feel when that happened, or what did it look like for you after it happened? So, and ask specific questions about peer rejection, teasing, and bullying from early childhood forward. So, you know, even if you're working with an adolescent or young adult, and they're talking about some things that are happening currently, chances are pretty high that they may have had some of the same things happening earlier on in childhood, which could also be affecting them. This is another very common area I see. The trauma goes way back. So, and one of the things that I do before I even start, you know, treating for trauma is to create a trauma timeline with my clients. And I don't have it in this presentation, but you can just do it on a sheet of paper. There's nothing special about it you don't have to use a special template, but just going through with them, what is the earliest experience you remembered? And you don't have to use the word trauma. You can use good and bad experiences. What's the earliest, bad or negative experience you can remember? And then charting it on a timeline. And oftentimes you'll see that it will go way back, even to, I have clients that I work with now that those experiences go back into kindergarten and sometimes even earlier, and they're high school students and they remember all of that and it's affecting them now. So again, just to be aware and to ask the questions, and if it's not, direct questions of when did your trauma begin, it may more look like, let's talk about some things that were really good that happened in your life, and let's look at some things that weren't so good, and what are your first memories of those, and important to normalize by putting in the good memories too, so they're not on the spot, but just getting somehow to get that timeline of what, how many years have they been exposed to this rejection or teasing or bullying. So certainly helpful when moving forward, even to typical trauma protocols. Asd and Eating Disorders. This is another area where it could be very difficult to discern whether it's an actual eating disorder or if it's more of the course and Asd symptom. 20% of individuals with Asd do have an eating disorder. So considering, is it disordered eating versus eating disorder? So food sensitivities and selectivity that are oftentimes seen in individuals with Asd, or is it an actual meeting criterion for an eating disorder? Also taking into considerations their sensory challenges with texture and taste and smell. Is that maybe why they're not eating? Like say they're, in a setting where, maybe it's in the school setting and they usually bring their lunch, and all of a sudden they start buying their lunch and they're not eating. Is it because they have an eating disorder, or is it more of the challenge with not, having the food that they're okay with that they brought from home? Now they have some challenges with texture or smell or taste. Sometimes ritualistic behaviors around food as well. And the weight, and this is something, again, where those different components kind of bleed over into each other. So that perseveration that we see in our individuals with Asd can actually move over to weight. And they can become obsessed with counting calories or charting what they eat, or and that can be their special interest now. And yes, it can look like an eating disorder and have a lot of the symptoms of an eating disorder, when it in fact is become their that's area of perseveration or their area of special interest. And perfectionism, certainly another piece to think about with body image, and that's certainly something very common seen in all adolescents and young adults. I have included some assessments and screenings for eating disorders, self-reports, and free screenings that you can find online again. But making sure, and there's certainly more than what I've included here. I've included just a few. But making sure assessing for food sensitivities and selectivities as a cause to what might appear as an eating disorder is so important. But again, the assessment, and maybe they're not going to confide all the things that is going on for them, and maybe we're concerned that it could be an eating disorder. Let me do a screening and start the conversation with them just to assess. So Asd and sleep disorders, as I mentioned earlier, it's so very common and so impactful. I oftentimes, so I work with a few psychiatrists who see patients with Asd, and oftentimes they want to, work on the sleep piece as one of the main pieces when they're looking at medication assessment. It's that important because if the sleep is too disordered, then it's really hard to get symptoms of depression and other mental health pieces under control. So it is so important to assess, for, what the sleep pattern, the sleep hygiene is. Research varies, but studies suggest 40 to 80% of individuals with ASD have sleep problems. Most individuals in that range of experiencing problems will experience insomnia or daytime sleepiness with nighttime wakefulness, causing disruption of the circadian rhythms, which is part of what the psychiatrists I work with try to get back into rhythm, the circadian rhythms, get them back into a healthier place. And it's so important to know here that sleep problems in ASD have such a big impact on not only social interaction, but day-to-day life and academic achievement. And so it's so important to assess not only, so what is commonly seen, or what I commonly see and have seen over the years, is that day-night reversals, particularly in adolescence and young adulthood. And what are the underlying causes attributed to it? What is causing that sleep hygiene to be so off? Is it, ASD symptoms? Is it the life cycle changes? Is it a mental health disorder? And again, what was the baseline? Has it always been difficult? Have they always struggled with sleep hygiene? Is it more than what was seen in the past? All of those things, so important. ASD and substance use disorders, particularly important to assess for this, or at least screen or start a conversation about it in adolescents and young adults, because they oftentimes will begin to self-medicate the things that they're struggling with. So that social anxiety, the anxiety, there's the regular anxiety, depression, anything that can just make it better. And oftentimes, that self-medication starts and it can get out of control because it, in some instances, it really does take the anxiety away for them. And certainly it's something that isn't a good idea, and it's not going to continue to do that. It's going to, it's going to turn around and become even worse. But certainly, if they're starting to self-medicate and they're realizing, okay, my symptom feels a little better, then we have to make sure that, it's not getting into a substance use disorder. And adverse childhood experiences, including chronic bullying suffered by adolescents with ASD, can lead to a substance use disorder. And this can lead to an adulthood of debilitating self-medicating. So very important to make sure that we screen for this, or at least start the conversation and have that on our radar. I have one of the assessments available for free here. You can find it online for screening for substance abuse disorders. It's a very short questionnaire, but it's more about starting the conversation. You don't necessarily have to use the screening, maybe asking direct questions pertaining to the use of substances, just to get the conversation started. But however you can get the conversation started, it is very important to make sure that's also on the radar, to be sure that we can prevent it from getting worse. Asd and psychosis, this is another area. There's some crossover symptoms, certainly. It's very important to assess and screen for psychosis, particularly because symptoms of psychosis develop or happen when in adolescence or early adulthood. So definitely, if there's something going on there where there's a question, assessing or screening, because early treatment is so important in the arena of psychotic disorders such as schizophrenia, schizoaffective disorders. individuals with ASD are not immune to psychotic disorders. They actually experience them at the same rate as the general population. That's really important to know. They can coexist, and misdiagnosis is really common. Social withdrawal and communication impairment, this poor eye contact that we see in our individuals with ASD are very similar to the negative symptoms seen in youth with schizophrenia. However, the positive symptoms, the hallucinations, the delusions, hearing things or seeing things that aren't there, those are hallucinations. The delusions, believing things that can't be true, like I'm being controlled by, someone's controlling all my actions. They're reading everything I think, that kind of thing, that delusional type behavior. If you worry about that, or you're seeing some symptoms of that, or you're even unsure of whether it's, something more in line with, oftentimes when individuals with ASDs, particularly in adolescence and young adulthood, get really stressed, they can look a little bit like they're paranoid, but and if that is occurring and there's a concern, doing the assessment and screening for psychosis is really important. I've listed some of the assessments and screenings here for screening psychosis. And again, some of these are available and you can find them on the web. But certainly, if there is a concern, it's always better to assess or screen and make sure that that's not a comorbid diagnosis or struggle that's going on, so that it can be treated. So now we're at the point where I want to incorporate everything I talked about and help you to see how that could look in a case conceptualization, regardless of whether it's in an educational setting, it's in a clinical setting. What the big picture is here is we need to incorporate core ASD symptoms, the life cycle challenges or the life skills deficits, and the mental health symptoms in treatment so that we have the best outcome and so that we're successful. So it's so important that, not only do we consider all these things, and I've gone over the difficulties that we can have in parsing out which is which, and how we know, when, which one is the mental health and which one's the life skill deficit and which one's the core symptom. The bigger picture is that we provide the support that the individual needs. So it more than being able to say definitively, this is what it is. It's the ASD symptom, or this is what it is. It's the anxiety. The most important thing is that we just make sure that we incorporate all the support the individual needs into our treatment and support for them. So, and another area is to make sure that we take in consideration what their strengths are, because those are many, and as with all individuals, there's many strengths there as well. And it's so important that we don't focus only on the presenting difficulties, but that we also, incorporate strengths even when we're working to support the difficulties. And it's really important to involve the adolescents and young adults into the treatment planning, so they don't feel like at that age they're starting to, particularly in the therapy setting, it's almost like modeling what you would expect for if it was a neurotypical individual that you were working with. You want to make sure that you include them. So it might be, this is what all the screening showed, or this is what I feel like, how do you feel about treating the anxiety? However you can include them is so important, because at the age we're talking about is, that you definitely want to teach that self-advocacy, and part of it is allowing them to take part in this treatment planning and not so much that this is your plan and this is what we're going to do, but how do you feel about this? Is this, the struggle you want to work on first? And getting any kind of input that you can, but also getting, knowing that our teens and our young adults might still need significant support from parents, caregivers, teachers. So we want to include them as well. So, providing a comprehensive intake interview to determine strengths, the presenting difficulties, and current level of functioning. Collecting data from individual educators, school, parents, and caretakers. It's always helpful to take a developmental history so that you understand what their development was like, any struggles that they had that might still be, a struggle for them now. Reviewing any prior assessments and reports is really important, IEPs included. Providing, and then going on to the next step of providing the appropriate screenings and assessments once that the comprehensive intake is done. Looking at and screening for the Asd core symptoms, screening for life cycle challenges and life skill deficits, and looking at those assessments to understand, what are the unique challenges here? Is it, related to transition, mental health? And again, I know this is very difficult, but knowing that all those components all play into each other. Collecting data from comprehensive interview, and consultation and screenings, and then determining the core Asd symptoms that might be causing the most daily distress that are linked to the mental health symptoms, determining the education and skills necessary to address the life cycle challenges, and creating a treatment plan that addresses the full range of symptoms and challenges, and identifying the supports that and where they're going to happen. Are they going to happen in the school? Are they going to happen at home? Are they going to happen in therapy session? Or are they going to happen in all environments? So common strengths in adolescents and young adults with ASD: memory skills, attention to detail. They're very honest and direct and rule-oriented, and extensive knowledge on preferred topics. That's always a good area to incorporate into treatment, the extensive knowledge on the preferred topics. So I wanted to use a case example here when putting it all together, because I know it's a lot, and I know I've only had an hour, and it's a lot to pack into an hour and expect that, it's all going to be understood. So I'm trying to put it into context a little bit to at least, and this is more of an overview of everything, this presentation. Certainly so much more is required to understand all these components, but I think it's a wonderful start to even have it on the radar that these are all the components that we need to, thinking about one of the initial slides of the, the mental health therapists that don't have any experience in ASD and the ASD professionals that don't have experience in mental health, and kind of bringing those together, and how would that look? So I have Thomas, and he's a 16-year-old high school student. He has severe anxiety, difficulty sleeping, and daytime sleepiness. He's been isolating, doesn't have any friends anymore, will not engage with family, has school avoidance, and he feels sad. He no longer participates in the things he really enjoyed. So looking at, after the assessment, looking at what are his core ASD symptoms. Limited capacity to engage in activities that maintain peer relationships. Spoken communication is repetitive and unstructured, difficulty with change, inability to regulate emotions, and difficulty, the organizational piece or the executive functioning, the difficulty focusing in class, very disorganized. The life cycle changes. He's being teased by his peers for inappropriate emotional reactions he's having. He wants to have a girlfriend, but he has deficits in relationship and friendship skills. Work and study skills, again, those executive functioning and the increased academic demands. He's not able to organize his school assignments. There's some issues with hygiene contributing to the teasing by peers. And also he'd like to get his driver's license. That's something that's really bothering him, and he's unable to do that. And it's not, determined yet if that's something he can ever do. His mental health symptoms, he's had changes in mood. He's irritable, angry, and anxious, and sleep problems. He's having panic attacks and a very high level of anxiety, particularly at school. He doesn't want to attend school. He will not spend time with his family. He's spending 6 to 8 hours per day gaming. That's something that might resonate with all of you when you hear that. That often goes hand in hand with the isolating, and then certainly plays a huge part in depression. He's very depressed, negative thought, rumination, does not enjoy his previously enjoyed activities. So how might this look with treatment goals? And I've placed here on this sheet, after completing interview screenings and parent-teacher reports, so this, maybe not looking like the typical treatment plan in mental health, in the mental health realm, but knowing that regardless, again, whether it's in the educational setting or it is in, mental health counselor's office or psychologist's office, we can't just treat the depression that he's experiencing. We need to treat the depression, but we also need to know what we need to do to, provide the skills, provide the other support that is needed to actually be successful with, treating the depression. So I have conflict resolution skills and emotion regulation skills, increasing self-awareness, insight into other people's thoughts and feelings, some of the theory of mind stuff. Teaching friendship and relationship skills to decrease isolation and community, allowed to be involved in community and more involved in school. Teaching skills to handle the teasing, in addition to, as I suggested earlier, treating trauma, providing skills, whether it's teasing or bullying, that's so important. Teaching proper hygiene practices, that's so important as well. That was part of why, the peers were teasing him. So it's not enough to just work on okay, you're depressed because, but we also need to incorporate that into treatment planning. The routine, which is so big and so important, regardless of if an individual has ASD or not. Having that healthy routine, teaching organizational and executive functioning skills for, particularly in the school setting, and, for use in the home setting as well, with organizing, study time and all the things that, certainly are under that life skill realm. Self-advocacy skills, asking for help when it's needed, letting teacher know when, when you didn't understand something, all those really important things, not only so important for, success in the school setting, but also success in life. And then the mental health type techniques that we would generally consider under mental health, which, teaching relaxation skills, coping skills, and anxiety management skills, the sleep hygiene, the CBT for anxiety and depression. A couple other tools here, the trauma stuff, teaching transitional life skills. So that based on what the screening for life skills came out as, and making sure that we, understand the challenges that are happening for Thomas in the high school and the post-high school realm, and what needs to happen there. Also the parent caregiver education. So again, thinking about getting everybody on the same page, on the same team. That's the parent, caretaker, clinician, educator. We're all on the same team here. We understand, and I have off to the right here, is it going to happen in the clinical setting, in school setting, the home setting, all three. certainly many of them in both the educational setting and the clinical setting. So again, just a little bit of a glimpse at what a treatment planning or case conceptualization would look like for an adolescent or young adult with ASD. Another really helpful tool when doing the case conceptualization is the CBT, or the cognitive behavioral therapy for Ps. And this can be really helpful to help the clinician or regardless of what setting they're in, whether it's the educational setting or the clinical counseling setting, just to understand the predisposing factors, the things that might have increased vulnerability, like early challenges, personality characteristics included as well. Also precipitating factors that might trigger mental health symptoms, the good and bad stressors. So even good stressors can trigger it. I get to be involved in an activity. I've been looking forward to it, but I'm really scared because maybe they don't have the skills, or their anxiety is getting, out of control when they're considering being a part of the, activity. So even, again, even good can cause stress. Perpetuating factors that maintain the symptoms, really important to look at. And then of course the protective resilience factors. And these are really important: getting sleep, all the healthy stuff, the stress management, the having, all the tools you need to regulate, anxiety, making sure sleep schedules on, is healthy. Parent support is very, helpful. And IEP goals that address anxiety, the executive functioning deficits and social deficits and the teasing. And so any of those things that can be really helpful to, to address all the other Ps that are in here. The protective is really important as well. All right, so that is the end of my presentation. I want to thank you so much for watching, and I know it was a lot of information in a short amount of time, but my hope is that you can walk away at least knowing what needs to happen, what components need to be considered when working with teens and young adults with ASD. Thank you so much.